Now I want to introduce our evaluation advisory and technical team. We call them the EAT team, which we think is kind of, apropos. And they will be talking about both the qualitative pieces of process evaluation that we're extracting from this work, as well as the quantitative components of this work. I'm going to introduce all three, and then they're going to come up individually to kind of talk about their components. Their bios, their full bios are in your packet, so I'm not going to go through each of those. Our first speaker will be Dr. Marianna Weatherill. She is a scientist at OU. She is really providing a lot of kind of the overall strategic vision for food as medicine for us. The next speaker then will be Dr. Kristina Bridges from the University of Kansas Medical Center in Kansas City. Kristina is leading up the quantitative piece of the clinical data collection that comes through the REDCap system that we're utilizing with the clinics. And then our last speaker will be Dr. Susan Harvey, the University of Kansas Lawrence campus. And Dr. Harvey is overseeing the process qualitative evaluation. So she'll talk about what she's learning on her site visits to the clinics and with the food banks. So with that, I'm going to turn it over to Dr. Weatherill.
So as we just think about, that broader view and taking that part into our evaluation approach. Can you advance the next slide for me? Because it's not working. Perfect. Okay, thank you. So I think that we generally agree. There might be a little bit of squabbling here and there about what foods specifically are best for health, but generally I think everyone in the room agrees that, transitioning away from an ultra-processed diet to incorporating more whole foods, whether it be fruits, vegetables, whole grains, beans, higher fiber foods, meats that aren't highly processed, all of that can bring a lot of health benefits, regardless of whatever specific chronic disease a person might be living with. So that is the theory. We have a lot of science behind that to support it. But then the questions that we're working with now in this space is, well, how do you actually implement these theories into practice? We have a lot of challenges of not only working within a healthcare system, but also within a food system, and then also trying to influence change at an individual level. And for an evaluation team, that's a lot of pieces that we're trying to capture and pull together and synthesize, that as we move this work forward, we can better determine what types of resources are needed to help scale programs. Where do we need to invest? Where do we need to build capacity? And then also maybe who hasn't yet been at the planning table that needs to be brought in further into these conversations. Okay, Elizabeth? No, it's okay. So during this process, which is really pulling together both intervention science as well as a newer concept called implementation science, with a lot of different moving parts. Our team, and I think the Sunflower Foundation as well, we have some very strong commitments to how we want to prioritize this work that we thought was really important to share with you. So our goal is first, in recognizing that all the clinics are different, our goal is to support best practices, but in the ways that make the most sense with the realities that the clinics might be working in, and how to pivot and respond to maybe things that we might not fully be able to do, but how can we problem solve and brainstorm through challenges so that patients really are getting foods, for example, that we feel are evidence-based for giving the kind of health outcomes that we want. We're also really committed to sharing key lessons learned, including wins, challenges, opportunities for continued growth, improvement, et cetera, and making sure we're sharing that information in as real time as possible, both for our pre-implementation work, which we have closed out, and then as we move ahead with this implementation phase. And then, as I alluded to, we're also committed to capturing within our resources that we have a variety of outcomes data, so that the data that we are gathering are meaningful to different types of stakeholder and not just one stakeholder. Our team has tried to develop a plan that's as comprehensive as possible. But I think one of the benefits of working in partnership with community is that if you see something that you think should be captured that we're not capturing, we want those suggestions so that we can incorporate it into our evaluation work. And then finally, we feel like we have an obligation to disseminate what's learned during this process, not only to the state, but then also regionally and nationally, so that Kansas can show really the novelty of what they're doing, the innovation of what they're doing, so that other states can benefit from this work. Whoa. Oh, no, it's okay. It's okay. So Brandon already covered the summary of what was done, but there's a term called pre-implementation planning that's used in innovation science. And so we're kind of trying to describe it as that. We've also been calling it the planning phase and the scoping phase, but it's all pretty much the same. But basically, we have accomplished a lot, even though it feels like we're just now starting the implementation work. But we've, I think, have done a really good job at naming the problem, identifying stakeholders initially that need to be involved, wading through those evidence-based practices of, what types of nutrition prescriptions would be best for the different food as medicine programs, thinking about all those elements, not only to make sure that we have a good initial launch, but then also that we've thought about what actually is sustainable and practical within the clinics. And then also this type of pre-implementation planning is really important for those cross-sector types of projects, which arguably food as medicine is. Okay, and then Brandon already went over this timeline, so I don't need to do it for you. But this is just an example of the type of dissemination that we would like to share, so that other foundations and other coalition groups might be able to understand the framework, like, well, what was covered during learning collaboratives? What topics were covered during the trainings? Were there homework assignments? What was covered, so that maybe they could replicate some of these things. We did survey clinics to ask about what elements of the training was useful, and we were delighted to see that they pretty much said everything was either very useful or highly useful. And then also that the pre-implementation work that we did was very influential in shaping the final direction of the Food as Medicine project. However, I think a key learning from this stage of the evaluation was that they also reported, though, that some ongoing support is needed from the sponsoring agency during the actual implementation phase. So it's not enough just to do some guided workshops and then give money to people and say, okay, go launch your program, you'll do a great job. That there's still some systems level capacity development that has to be done. Next slide. And so some of those investments of continued support that clinics asked for and that Sunflower Foundation decided to invest in were events like this, collaborative learning events. All clinics had requested those. Also suggested lists of food specifically that might be used for food as medicine interventions for diabetes or pre-diabetes, ongoing evaluation support, and access to a registered dietitian, whether it be for consultation or technical assistance was also requested, and then having a time to sit down one-on-one with trainers and to provide technical assistance. And then this is my last slide. Just wanted to be transparent about what our dissemination goals are for this year. I'm a community-based participatory researcher, and so I do see this project very much as being a participatory research project. You all are giving information one way or another, and we're making decisions together. So our plans right now are to write a manuscript and get that published in a peer-reviewed journal that would be open access, which means anyone can read it, download it without having to pay a fee. We feel like that's really important from an equity perspective, that would be describing basically what's happened thus far. We'd also like to present that information at a national conference such as the American Public Health Association conference. And then the information that Dr. Harvey and Dr. Bridges are going to present now would be the focus of a second paper of those key lessons learned during the implementation. What are the initial outcomes from the work that we're seeing? And similarly, those would be published in the same way and presented. And then additionally, we're in the very early stages, and we'll talk about this just a little bit more in the afternoon, of planning a regional food as medicine event that we hope will actually be at the Sunflower Foundation, but that would be hosted with the Aspen Institute, which for those of you who have been here since the start, we actually initiated our training with talking about the Aspen Institute Food as Medicine Action Plan. And so bringing in those additional experts to talk about what are some regional opportunities and to share best practices of what's being learned in this space. So turn it over to you now. Okay. Yeah.
Hi, good morning. I'm Kristina Bridges, and I've had the pleasure of working with each of the 6 clinics to collect common data into one place so that we can do some of the outcomes evaluation that we talked about, along with the qualitative process evaluation. And so it's been a good and learning experience to figure out how to get data from 6 different sources, and we worked it out really well, and everyone's been great about that. But we did that because we wanted to not only be able to evaluate each clinic individually, but to have some collective evaluation for the state together. And so yesterday we got to spend the whole day with the clinics and kind of go in depth about their implementation process and talk about what data we've been able to collect so far from 4 of the 6 sites who have started. And we see all of you as participants in this, kind of as Marianna just suggested. And so we also wanted to share that with you all, even though this is just very preliminary and sort of internal. So we, like I said, 4 of the 6 clinics have started implementing. 1 started in November, then December, January, February. So we kind of having this rolling. So each clinic is at starting from a different readiness state and preparedness state. But we have 66 folks who have been enrolled over those 4 clinics. And for 1 clinic, the one who started the earliest, we have 17 participants who actually have completed their 3-month intervention, which was weekly food and some diabetes specific nutrition education and visit with a primary care physician. So at the very end, we'll just show just the very preliminary initial results for their A1C, which is measuring their blood sugar over 3 months. And that's kind of one of our standard, how are they doing with control of diabetes? And so we really wanted to share, kind of look at this to say, who are we reaching and, how can we make a difference? And so first, who are the people that are enrolling in these programs across the 4 clinics? And so together with each of the clinics, our evaluation team, we designed a survey that can be given at enrollment and then at the end of their intervention. And every intervention is slightly different, but most of them are about 3 months with weekly food delivery and some education. There is variation between the clinics, however. And so these surveys are a way to get to know who are we working with. So lots of demographic questions, lots of health questions to get an understanding of where they are at baseline when they start this intervention, a lot of mental health questions, and also some biomarkers. So A1C, like I mentioned, blood pressure and weight. All right, so first, just a little overall demographics. So mostly women, 62% women, which is really common for this type of intervention. And we actually think this is a little more balanced than we see in the literature sometimes. So we're getting men also in these studies. Most 3/4 of the population are between 40 and 69 with a mean age of 48. We calculated based on their household income and their household size that half of the participants live at or below the poverty line. and 58% had a high school education or less. Also, 3% of folks identified as American Indian or Alaska Native, 14% identified as Hispanic, 18% identified as Black, and 61% of participants identified as white. So a little bit about their health profile. Starting out, 90% of folks have diabetes and the rest have prediabetes. 40% of folks met the criteria for mild to moderately severe depression. And then another 20% had some it's called minimal depression based on the PHQ-9, which is the depression screener typically used. So 0% of them rated their health as very good. Almost 70% were poor to fair was their initial health rating for themselves, and 68% also had hypertension. 100% of folks were food insecure. 74% of them rated their diet as fair or poor at the beginning. A third of them reported having barriers to accessing fruits or vegetables. So we said, agree or disagree, it's easy to access fruits and vegetables in my local community, and a third of them either strongly disagreed or disagreed. And then most of them are buying their food at a grocery store rather than going to food pantries, or rather than a supermarket like Walmart or something. So just looking a little bit more closely at food security. So as I said, 100% of folks were food insecure, which means they answered at least one of these questions, yes. And only 4 people, however, only answered one. So everyone else answered at 2 or more of these questions. A quarter of folks answered yes to every single question, which means they would be classified as very low food security. So our survey included diet, quality. So what are you eating? We asked them on average how often they eat different things. And from that, we could tell that none of them, or very few of them, are meeting the recommendations. So for fruit, we have a goal of 2+ servings of fruit a day, and only 8% are at that goal. For nuts and seeds, more than 4 servings a week, and only 19% were at that goal. We put a very low goal of vegetables at 2 or more servings a day. Really, it's 3 or more servings a day, and actually a lot of people will say 5 or more servings a day. But even at that low 2 or more servings of vegetables a day, only 2% of our folks were meeting that goal. And for grains, 1 serving a day, only 4% of folks were eating that. And then what are they drinking? They reported their water intake. 40% of folks weren't even drinking three glasses of water a day. 21% were reporting daily or more sugar sweetened soda. And then 20% were reporting daily or more sugar sweetened coffee or tea. We also noticed that it just overall their fluid intake was reported as very low. And so this could be perhaps a target area for hydration. Okay, so we looked at the A1C that came out of these 17 folks who did complete at one of the clinics, because that's kind of your first marker that you want to go to see, is this making a difference? And this is what we found. So baseline for those folks, their A1C, which is again that 3-month kind of average of your blood sugar, was 11.8. Over 7 is really where these long-term health concerns take off and the risk is elevated. So after the 3 months, 11 out of the 17 had improved glycemic control, so had reduced their A1C. The average decrease was 2.6%. And 5 of those folks actually went from over 9 to under 9, which is also another benchmark of control for your A1C. That overall decrease from 11.8, the average at baseline, and the average at after was 10.3. And that, even though we have a low or a small sample size here to work with, it actually was statistically significant. So we are showing a real improvement. And just for context, the clinical significance is that even a 1% decrease in A1C will reduce the risk for many complications. So we're excited about that, and we're going to continue, to collect these data and see how clinics are doing. All right, Susan, I think you are up.
All right. Good morning, everybody. Can everybody hear me? Okay. Everybody online? Okay. All right. Not a very good podium speaker, but let's see how we do here. No, that's okay. The handheld makes me want to sing karaoke, so let's stay away from that. So I want to briefly, because we all really want to hear from the clinic. So I'll quickly go through this. And then if you guys have questions, I'm around all day. So please feel free to come up to me. I'd love to chat with anybody. So I'm going to go over again, just kind of what is process evaluation, as well as what I found from both the clinic sites and the food bank sites. I want to kind of frame my presentation as, I think what we have been learning over the last several months is it's like putting together what feels like a 1,000,000-piece puzzle. And we're pulling all of these different pieces together finally. And I think, what somebody at a clinic yesterday said to me was, it's like we have this outer ring put together, and now we're starting to fill in all of these other pieces. So hopefully my slides aren't advancing. There we go. Okay. Am I able to do it? No, I'm not able to do it. Okay, that's the puzzle. Hopefully it didn't make people sick. So it's not showing up. It's not translating to up there. So I need the next slides. The process evaluation. Yes, that slide. Okay, so I think you guys are going to have to advance for me. It's not working up here. This is the formal definition of a process evaluation, but I think of it as looking at what's going on behind the scenes. And for us to be able to see what's going on from behind the scenes, we need that aspect of what's going on at the clinics, what's happening at the food banks, and all of these other partners that everybody's is starting to identify that needs to take part in this program as well. So it's looking at those different perspectives from behind the scenes and getting boots on the ground from understanding it. And also what Marianna also alluded to, and Kristina, this data, our outcome data and the process data, it really talks to each other, and we can learn. And there's strengths and weaknesses of both types of data collection, and any of the weaknesses from outcome or process are strengthened by combining both those quantitative and qualitative methods. So we're really learning a lot from the clinics as well as the food banks. Go ahead. So first, let me just talk about the clinic site visits. We have 4 main themes. So go ahead, and I'll just briefly go through these themes. So go ahead and go to that first main theme. With our first main theme, we really see a couple of different sub-themes. So the successes and then the challenges. And so what I've noticed is that each site has certainly benefited from having those provider and those staff champions that are inherently a part of the clinics. And they're the ones that are really turning the wheels, greasing the wheels, and getting the wheels moving on this project, in recruiting and finding those patients, and then serving as champions to communicate the benefits and what could really come about from taking part in these types of programming. And with that provider championship and the staff championship, that's motivated patients to also ask about the program as well, and to get excited about wanting to take part and finally changing behavior so that it changes how they feel, the quality and hopefully the quantity of life as well. And then the program integration, I think it's really interesting that each of the clinics have said, we've had all of these pieces of the puzzle, but they haven't maybe been integrated together. And now we can finally integrate them so that there's this one big holistic piece. And by the way, now we have these food partnerships as well. And that just adds to the robustness of this program and what we're able to offer. On the flip side of the successes comes the challenges. And so you can go ahead and advance. So it's interesting because the successes and the challenges have mirrored each other. So just as there's been provider and staff buy-in, there's also been some of that hesitation, and not so much hesitation of this program's not going to work. It's motivating patients to be able to think about this program and how it could really truly benefit them. As well as understanding that there is staff turnover, and that how that impacts the communication and the ongoing rollout of these programs. And staff had also identified, we've identified that we have patients that could really benefit. They've seemed excited about it, but when push comes to shove, there's a little bit of hesitation. It's kind of like getting the program going. You don't want to be the first one to do it. And I think it's the same thing with the patients too. It's really hard to be that first one to take that plunge and get going. So there has been some hesitation and a little bit of slow going with that patient recruitment. And then another challenge has just been staff is already, they wear a lot of different hats. And then the introduction of a new program adds to the number of hats that they're wearing, and trying to identify the roles and responsibilities that it takes to be able to continue this programming. So that program implementation, it is, again, trying to pull those different pieces of that puzzle together that I showed at the beginning, and understanding where everything fits and who fits where within those roles. So let's go on with theme 2. You'll see there's a lot of overlap with these themes. They all kind of bleed into each other, but I wanted to provide them separately just for a little bit more clarity. So just piggybacking off of what I said, another big finding that we've seen with these clinics is just the internal capacity. And when we talk about capacity, we're not only talking about the quantity of staff, but the quality. So some of those inherent attributes and skill and knowledge that the staff should have to be able to work with these unique patients. And so I think, where's Audrey? Audrey put it really good. So Audrey, yesterday, I'm going to call you out. From Community Health Center of Southeast Kansas, she said, we've got the organizational capacity, but it's that individual capacity that's really tough to overcome. So all the clinics are trying to overcome those challenges of staff turnover. Also the hiring of new staff and making sure that they have that knowledge and skill. But another thing that I've learned from talking with clinics, it goes beyond that knowledge and skill. It's also developing relationships and trust and familiarity with the patients, because that's also what's going to keep the program going as well. So capacity, the number of staff is certainly makes a difference, but that quality, the knowledge, skill, and those characteristics that are really important for building trust with patients is just as important, if not more important. With our next theme, we are so lucky that the clinics have the partnerships with the food banks. So Kansas Food Bank and Harvesters are two of our really critical and important partners within this grant as well. And so, just some of the comments that we've seen so far is behavior change doesn't happen overnight, and it takes a while. And when we've had patients that are used to specific diets or food preferences, trying to change maybe those food preferences and taste preferences can be difficult. And so there is patient pushback on sometimes what's offered, as well as just the availability of produce. The food banks do their best to be able to provide what they can to these clinics, but we have to realize that they're constrained also what's available to them, that they can also make available to clinics. So there are those challenges, but what we have seen just with the clinics is the resiliency and the adaptability of the food bank partnerships as well, to be able to listen to those needs of the clinics and be able to adapt. And then my final theme for the clinics is just the partnerships. We've learned that it goes to that saying, it takes a village. And we've learned that with, go ahead and advance the next slide. Thank you. We've learned that, back. Sorry. It does take a village. And so on top of the food bank partnerships, clinics are learning to tap into their local community resources and understanding how can they procure maybe additional food items, also providing education choices and peer education space to be able to store food boxes and to do cooking classes and other robust educational opportunities. So tapping into those local resources. And you guys will get to hear from Dr. Chris Long here in a little bit. I'm going to call you out. Where are you? Okay, way back there in the corner. Nobody puts baby in the corner. So, he put it eloquently yesterday when we talked, is that it's not the food necessarily that's changing those A1C levels, but it's these other pieces as well, the education, the peer support, the support from the clinics and those providers and the staff members that are providing that one-on-one care and attention with these patients. So it really does take a village along with those million little pieces. And so go ahead and advance. And I do want to just briefly talk about our food banks, what I've learned from the food banks. I've had the opportunity to go to both food banks and excuse me, Craig and Jessica, I'll just call you both out. They did such a wonderful job of showing me around and really understanding that they are invested in this program as well and are interested in how they can form and maintain these partnerships with the clinics. And so along with them, they're also facing their own challenges, supply chain challenges that trickles down to the clinics and what's available as far as food items. They're also dealing with capacity and staff shortages and how that can also impact deliveries to the clinics. And then what's important, I think, to recognize is that they're learning from this process as well. And we are learning from them and how they can adapt to meet the clinic needs as well. Look at those. I don't know if you can see those very well, but both food banks are serving a huge area and thousands of people. And the fact that they're making a commitment to this project as well, I think speaks volumes about where maybe our food systems could eventually lead. And so with that, I took up way too much time. I'm sorry I ate into the clinic time. We really want to hear from the clinics, but if you would like to chat, please come up and see me. And thank you.